So, welcome back. I hope you enjoyed your coffee. I think the industry should think about something to personalize our coffee a bit more. Yeah. Because, we're all different. Every patient is different. Why are there so many different sizes in clothing? Because one size doesn't fit all. But when it comes to medicine, treatments are not tailored, or at least not enough. So, what you are doing here in this personalized medicine, I think it's a very important job. And Kathleen and Cynthia already talked about the roadmap for the future of medicine. Let's discuss this even further. We have our 4 panelists here. You already heard Janice Bailey. Next to her is Eva Maria Stegeman from Germany, Olivia Balagna, Italy, and Jonathan Gomez Racha, do I say this correct, from Spain. So welcome. And before we begin, you can perhaps even introduce yourself and your region. Jonathan, yeah?
Okay. Thank you very much. I'm coming from the region of Extremadura, so I'm taking the position of Chief Scientific Officer at the research foundation called Fundesalud, which is a foundation depending on the government of Extremadura, the Regional Ministry of Health and Social Services at the government. We basically are coordinating, managing and promoting all the research and innovation programs in the health and social care system in Extremadura. And that means also participating in this kind of activities and in different projects, some of them related to the personalized medicine, precision medicine, and so on. Basically, our infrastructure for the personalized medicine is based on the healthcare system, which involves 14 different hospitals and more than 500 primary care centers, all of them connected by the same healthcare information system. That means we have the entire population covered by our system, and it's a single medical record. So we can, follow every single patient, and not only the medical records, also the images, lab tests, and everything. So it's a base for implementing personalized medicine because we have the infrastructure. The problem, and we will let you know later. So the problem is we are not implementing that in a good sense, in my opinion, yet. So I think these kind of events and these kind of projects are really good to going further in implementing personalized medicine in the regional strategies. Thank you.
Okay, thank you. Olivia?
Hello, I'm Olivia Balagna. I work at the autonomous province of Trento in Italy, in the northern part of Italy, northeast. I work in the Department of Health and Social Policy in the Research and Innovation Office. So I mostly focus my work on e-health, digital health, and I will talk about that later in the environment of personalized medicine. I'm also part of and a member of something called, a competence center or ecosystem called Trentino 4.0 that I will explain later, who focus also on e-health. My region is actually a province in Italy. It's a small province with 500,000 inhabitants, and we have a large degree of autonomy, mainly on education and health. Which give us an importance on e-health because health is one of the most important topics that we deal with in our province, and so I'm happy to be there and discuss that further with you today. Thank you.
Thank you. Eva Maria?
So hello, I'm Eva Maria Stegemann from Saxony in Germany. I'm from the Science Ministry of Saxony, actually Science, Culture and Tourism. And I'm from the Department of European and International Affairs. So I'm not from the health sector, but we are participating in ERA permit and in regions for permit as well. And maybe first, a little bit about Saxony. Saxony is one of 13 German regions. The other, actually, it's NUTS level 1, as I understood it now. It's located in the eastern part of Germany, former German Democratic Republic. I think that's also important for our history. We have like 4 million inhabitants with an overall aging population, 23% above 65, and a gross domestic product of 125 million in 2020. In Saxony, there are roughly 2,600 general practitioners, more specialists, 4,500, 78 hospitals, 2 university clinics. So many rehab facilities, and so we have a very good health infrastructure. But actually, from what you described just now, like having an overall integrated health system where you have all the documentation, this would be nice to have. In Germany, we are very, very much lagging behind in this respect. Their patient data and patient data protection is on a high agenda in a way, and it's which means that patients need to carry their own data from doctor to doctor if they want to have it conveyed. And I think it's a difficult situation for doctors. I just recently attended a workshop of practitioners in Saxony that were really quite frustrated because they say there's a wealth of information in the system and we have high-end medicine, but the data that we generate is not used. It's not. And it's even not sufficiently used in treatment sometimes, but also not for research. So I think that's an important topic for personalized medicine help. So back to my ministry, we are participating in several ERA nets in Horizon Europe and Horizon 2020. And one of them is ERA permit. This was actually our entry point into personalized medicine in Saxony. So it comes more from the scientific agenda of Saxony. So we have in our innovation strategy, we have individualized medicine and e-health approaches. But personalized medicine as a topic, as a focus topic, I think is more in, a research and innovation topic right now. So from the policy point, in the social ministry, we have more a focus on digitalization and e-health, but this is always under the general German situation, which is also federally regulated, which makes things a little bit slow, I think. So, and overall, we have, in ERA permit, funded so far, I think, 12 projects with overall funding of 9 million euro. And within regions for permit, we've been responsible for the topic of personalizing health industry. So I've done a conference and 2 workshops on that topic, and I think the documentation will be out sometime next month, hopefully.
Okay. Thank you very much. Janice?
Well, I guess you've heard quite a lot from me already, so I'll try and not speak for too long, but just to kind of highlight Northern Ireland as a region itself. So our population of 1.8 million is served by 5 health and social care geographical trusts, which support around 400,000 people each. And we have an ambulance trust, which is regional. The sector in Northern Ireland employs around 8,500 people in life and health science in general. And
can you put your microphone a little bit closer,
sorry, I
please?
forgot about that.
Yeah.
Yeah, and so I suppose some of the things that I wanted to mention earlier are that, and someone was asking me in the break about our focus on diagnostics and where that had come from, and I think it's historically due to the investment that had been made in a more basic science model in the past, and the health departments in general have tried to shift more towards an applied science model.
So, but with our strength then having been built in diagnostics, we would focus in that area. But as a policy lead, we would really be keen to expand that further. And we've a small research community, same academics leading the development of personalised medicine interventions as the clinicians who are caring for patients. We're very keen, and we are investing quite a bit in the prevention agenda as well. And as regards data, as I said, we have really good data resources, and we have good access to a data warehouse with all anonymised data from secondary care. We have a general practice information portal, but the two are still to be linked in fully. And when we get to our new electronic health and social care record, at that point, the ambition is to seek permission for everyone's data to be made available for research. And as I was saying earlier, we're engaging the public in dialogue around how acceptable they will find that. So yeah, we're somewhere in between yourselves and Jonathan's region and Olivia. So lots of different models around the table.
Yeah, a lot of different models. And as I was preparing for this discussion, Kathleen told me that personalized medicine is often used as an umbrella term to group high technology driven innovation in healthcare. So no clear definition exists. So the SAPHIRE project used the definition given by the European Commission in 2015. And I don't know if I should quote, so we all understand what we are talking about. Personalized medicine may be defined as a medical model using characterization of individuals, phenotypes and genotypes for tailoring the right therapeutic strategy for the right person at the right time, and or to determine the predisposition to disease and or to deliver timely and targeted prevention. So that's what we are talking about. Jonathan, I start with you. What topics in personalized medicine are you most active on?
The most active project we have now, and actually most, for me, challenging is everything related with prescription, personalized prescription. And in this, we have a project called Medea Project, which is a project to implement a system to clinical support the practitioner to give the right med to the right people. Because, I mean, all these adverse reaction to the medication, most of them, 1/5 of the adverse reaction we have are because of the genetic profile of the patient. If we know that they are going to respond not really well to the medicine, so why don't you use that? So, and the idea is based on the infrastructure of data we have, as I told you, 14 different hospitals, 500 primary care center, all of them connected by the same system, having all the data from, regardless you are in the hospital or in the primary care, the healthcare professional has access to your profile, all the reports, all the lab tests, all the images, even all the administrative stuff and so on. So why we don't design algorithm, we don't design a system to read all this information, because sometimes the practitioner, the GP, when they prescribe, they don't read all the reports because they only have some minutes to in the consultation. So why don't we have a system, a software, something to read all the information and also to add the genomic profile of the patient into this. And we can have three different levels of information. The medical journal, the healthcare information system, the clinical profile, the genomic profile, and the third, the environment, all the gadgets and everything. Why we don't put this together? And the project is a PCP project, a pre-commercial procurement project. It started 4 years so far. Now we are in the call for tenders right now, attracting all the companies to provide solutions to this. And basically will be a system that when the GP prescribes, insert the card, we have a card for the healthcare system, insert the card into the system, and the system reads in all those three different information and says, okay, don't do that because this guy, first 10 years back, respond very bad for this medication, or because this guy has the profile one biomarker for this adverse reaction, or because the daily life it's not really because he's not good at physical activity or wherever. So the system can decide which drug is better for the patient based on the different information available. So in responding to your question, the most most active topic is everything related to pharmacogenomics. Yeah. So based on this project.
And prescription, because I hear you saying giving the right drug to the right patient.
Yeah.
That's a good beginning. Yeah. Olivia, what's it in your region, in Cento?
I'm happy to answer that after Jonathan, actually, because I don't want to publicize my region, but we have the answer to your problem. We actually have this wonderful thing. It is based on personal health records. Our personal health records in our region takes into account everything you just said, the context, the environment of the patient, the medical history, and hopefully external devices. We're working on that, but it's supposed to work also with external devices, monitoring device, well-being trackers, and everything. If when you ask in which in the umbrella what we focus on. Actually, I will answer on the e-health department because I'm working on this field, even though in my region we also work on genetics and also proton therapy. But on e-health, we are pretty good on developing this our ecosystem, who is the ecosystem where everything is all the data from the patient is collected. The doctors are connected to the platform as well. And I will talk about this platform later on as well. And we're also developing this personalized support and disease management that Jonathan was talking about, and in particular about chronic diseases and diabetes and heart failures in particular. We started with that. Yeah. Yes.
Yeah. Now, Eva Maria, you already said in Saxony, in Germany, it's going very slow. But where do you focus on?
Well, I come from a totally different angle. I think that's important because we are not in patient care and healthcare, but we are in science and research and innovation. And I think that's a completely different game. It's interrelated, and I think and of course, clinicians are also medical practitioners. To some degree, they work in their clinics. But it's still a different angle, I think. And so what I can say for Saxony, I think we have some real lighthouses in Saxony that have developed with the competences that have been developed over time. Maybe I should say something to the history of Saxony. When after the German reunification, Saxony really had no strong life sciences base in terms of research and development. So there were the medical universities, so medical training also, but there was no real large life sciences foundation. And over the course of 30 years, there was really a nice infrastructure with new institutes of different research societies built. There was a so-called biotechnology initiative. There were investments about 1 billion euro over 20 years to invest also startup centers, incubators, and so on, and have this infrastructure apart from the research base that was grown. So now we have like expertise in different medical fields, but we have, I think, a real lighthouse which is called SAPHIRe, which has just received federal funding for, I think, up to 45 million years for up to 9 years. And this is about living therapies, cell therapies, CAR T cell therapies, for instance, but also gene therapies. We have experts in the Fraunhofer EC that are already involved in manufacturing and of these products for a big pharmaceutical company, because they're one of the 2 worldwide manufacturing sites. And we have the infrastructure already, and now we have really a system around cell therapies and gene therapies that is being developed, a real innovation system, which is involving not only the Fraunhofer Institute, which is taking, I think, the lead infrastructure-wise, but also our universities and several other research institutes in Saxony and out of Saxony. So there's a real cluster in development, and I think it's a cluster that is significant beyond Saxony, even beyond Germany, and visible. And then there's another lighthouse, just briefly, which is called the Elsa Kröner-Fresenius Center for Digital Health at Technical University Dresden. And I think they have a very nice approach where they reverse the concept from bench to bed to from bed to bench. And this is an on-campus project to support the development of digital medicine and to digitalize products for the clinic, with the knowledge of engineers on one hand and on medical practitioners and patients on the other hand, and where on-campus collaboration is strongly supported, also with funding, and projects are becoming possible that have not really been possible before, because there was just no funding for groups from different areas to work together. And which is, I think, nice. There's also the first tenure track set up. There are 5 new professorships associated with this. And 1 tenure track is on regulatory science. And I think it's the first in Germany. I think this is very important also so there are things moving on the research end. And I think there we are also at the forefront.
Okay, we'll talk about funding a little bit later on, furthermore. Janice, you, in your keynote, you were saying, I wish I would have had this roadmap. What recommendations could you take from this, from what Kathleen and Cynthia were saying?
So I guess the all of the different building blocks that we had in place, that we have in place now, due to our investment in the different elements of stratified medicine as it was then and now becomes personalised and precision medicine. There have been lots of different generations of it as we went along. I suppose the city deals have now are going to give us the kind of additional funding that we need to build on those. And I think the main thing that we need to do is to bring all those elements together. So, and that's going to be really underpinned by our new system, our new electronic healthcare record, which the one that we have at the moment, it covers the whole population, but it's not, I suppose it's kind of got old, and we need to replace it with something that's a lot more searchable and interactive, that's linked up with all the different dimensions that have been described by Olivia and Jonathan. So I think when we have that, it'll be transformative for us, and it should accelerate us right into that space where it seems they so enviably find themselves already, where, you know, you can take your records right from GP into secondary care, but also have have a handle on it as a patient and a service user yourself. So that's, I think, where we are headed,
Yeah.
but we're not quite there yet.
It should speed up. Yeah, I saw you nodding all the time, Jonathan. So you agree?
Yeah, absolutely. Basically, we have a problem about our system is it's getting old for sure. It's getting updates every time, improvements and so on. And we have a department of 50 people working every day to keep the system up and running only. But the thing is, the system is focused on how to manage, the patient journey, how to, prescribe, to go to the operation room, to get the profile, the medical records and so on. But it's not focused or it's not designed for research. It's not designed to, it's designed to put many information inside, but not getting too much out. To do research, you have to extract all the information in, different sheets and different, data and in Excel files or Access or whatever, and you have to do data mining. So, and we don't want that, because you need many human resources to do that, and also the clinicians are concerned about this. So they are putting a lot of information inside, but when they have to, extract information to see, the patient profile over the time and so on, they are not able. So, and this is one of our major, concerns about our system. And, if you add genomic profiles inside, so you are getting the system even more complicated. So we have to rethink about this.
Yeah, so collecting data and digital transformation should be better. No, what about the policy framework? I heard Kathleen saying we all should speak the same language. What about that, Janice, on the policy framework? How to stimulate and ameliorate the dialogue between policymakers, researchers, industry, healthcare practitioners?
Yeah, I get, so some of the examples of this before would have been sort of telemonitoring and mobile healthcare, where actually probably some of the most difficult people to engage were the practitioners themselves, because
Really?
they kind of felt that it wasn't easy to move over, and they gave up very easily. They just wanted to get on with
Well,
their...
why do they do that?
Yeah.
Why?
Well, I don't know, but I think we have to learn that lesson, and we have to avoid that happening in the new system that we put in place, for sure. We need to make sure that everyone adopts it. But implementing a new system like that, it's not trivial. It's actually very, very
It's hard.
intensive.
Yeah.
And a large part of it will be the hearts and minds.
Yeah.
I think the policymakers in our region are there. I think it's just getting everybody moved over and having the data literacy that they need to actually use the system. There's a lot in all of that.
Yeah. Eva Maria?
The systems also need to work.
Yeah.
But to come to a dialogue, I think that was the initial question.
Yeah,
I think that is, it's not easy, because I think there are also sometimes
Too many parties, or?
hesitations, to talk. It's also facing industry, for instance.
Yeah.
Big industry
Lack of trust.
is a different type of player.
Yeah.
But I think it's very important to have occasions to come into discussion again, and to have initiatives like Regions for Permit, for instance, or SAPHIRE, where you also have dialogue ongoing with audiences, where stakeholders talk to each other and learn from each other. And I think this type of dialogue should go on. It should probably go on in a bigger forum like EP Permit. I think this is maybe really an opportunity to bring together. I think dialogue is also happening in the Innovative Health Initiative, for instance, between different partners. But I think for personalized medicine, there needs to be a platform for continuous dialogue
Yeah.
overall, and also within regions or countries. That is not easy because it takes an initiative to set up a dialogue. It's not done on its own. It takes dedication, and it takes some effort to bring the right people together, and it takes some experience and knowledge.
Yeah, of course, but
it's not
dedication,
easy.
but it's for a very important cause. So, communication. I hear you saying. Olivia, I saw you nodding. Also, is that your experience also?
Yes and no. What we in our region, what we've done to respond to a better communication is about 7 years ago, we create a competence center with the different local actors, which are the Research Center, ourselves, the Autonomous Province of Trento, and the Healthcare Trust. We called it Trentino Salute 4.0, and it's a competence center who is now aligned with all the programming scheme of the region. Yeah, we are a small region with 500,000 inhabitants, so it's pretty it's easier to do that. I understand, but we are all aligned with the political governance and views. And so what we've done also to ameliorate, to have a better dialogue is to involve as well citizens. And how we did that, we developed a living labs approach. So we invited citizens and also practitioners, researchers to sit together and do co-creating an experience and developing and helping us developing our innovation and practices. And so this helped us through the years to better understand what practitioners, citizens, and needed, and to get aligned together to work better.
Yeah. So the regional government can play an important role in this.
Excuse me?
The regional government can play an important role in this.
The regional ourselves.
Yeah.
For the Autonomous Province of Trento is the decision maker for that, yes.
Yeah, and how do they do it? By involving the public, is that it? Yeah?
Yeah.
Janice?
Yeah, I think that's what has happened that's better this time around for us. That there's definitely
Your microphone, please. Yeah.
Put the public data panel in place this time. So although it's early days, we've already got that going. And I think as well, there have been roadshows around our new healthcare record that have raised awareness. And I think there's a lot more optimism this time around this new system. So I'm hopeful that we will see a better take-up whenever it's implemented.
Yeah, roadshows. That sounds sexy, huh? Jonathan? Yeah. Is there a need for demonstration and pilot projects to train the skills of all the people involved?
Yes, for sure. You need one word which is, for me, is really important, which is adoption in the end. And adoption not only for the users that are actually the patients, also for the clinicians, for the healthcare professionals. Because you can put many tools available, and actually we have many tools available, but if you don't train, if you don't engage them from the beginning, when you design the new tool for, because in the end you're gonna change the way they work every day. So if you don't engage them from the beginning, you are not gonna be a success.
But why is it so hard? Is it a lack of time? Is it a lack of interest from the healthcare professionals?
Basically, it's a lack of time. They are overwhelmed, and also lack of planning from the beginning. So users are really important. So you need to cover a need they have. Not a need in the system, a need in the users. And I think everything related to co-design, as Olivia said, living lab approach, everything related to that. It's the only way we are going to have a real digital transformation in the health and care system.
Yeah. Eva Maria, would you like to add something?
No, I think that's really important. You know, you also to have pilot projects in Germany. You could see this. Baden-Württemberg, another region in Germany that is active in the field of personalized medicine, has created centers for personalized medicine, and this concept was really successful, and has been transferred, or is currently being transferred, also with the corresponding different legislation on the federal level, to the German comprehensive cancer centers. So it's spread out to 14 other centers in Germany, where a personalized medicine approach in oncology, and I think it's rare diseases, is now advanced. And so this can be further developed. So I think you need model projects that work well, can be, of course, transferred sometimes, but that's also a problem. They can also, of course, be a dead end if you don't get them into the system. And the larger the structure, I think in a large country like Germany, where you have many different regions, these processes take time, and sometimes they just do not succeed. You have very good approaches, and you just, maybe the time is not ripe, because you have many different steps to take until you come to,
Yeah, you already talked
implementation.
about the funding, because research costs a lot of money. How do you cope with that in your region? Yeah, Jonathan?
Funding is the most important word. But I think you have to, if you want to have the government engaged, the government has to put funding as well. And the regional government, I'm meaning. So, because some of the basic infrastructure you need, so will come from your own funding. I mean, for example, European regional development funds or social funds or whatever coming from Europe, or other funding the region has to set up kind of a basic line, and basic also means basic research. Because if we think about new solution, new system to prescribe, everything is based on the capacities the region has in basic research as well, in clinical research as well. And this should be funded as a basic level by the government. Then you can move to other different kind of programs, national programs as we have, or European programs, Horizon Europe or Interreg or any other programs.
Yeah, so it should start there, but then eventually private funding?
Private as well.
Yeah, the industry? Perhaps?
On our side, private fundings, we never.
You don't work with that?
We don't work with that.
Why not?
Because we're mainly 96% of our infrastructure are public. Hospitals, medical centers, everything is public in Trentino.
Yeah.
About 4% of small infrastructure private companies, and so we need.
You're not open to a change?
We don't need to.
Okay.
We have enough public fundings to at the local level, and then we, like Jonathan said, we move to the national level. For example, with we're going to use a lot of the, thanks to the resilient plan, we'll receive a lot of fundings in the next few years. And then from the European level with programs, project from Horizon, but also we have one, for example, Erasmus project for, you talked about training, so we are much more focused on training now, and so we won two projects on Erasmus to train our practitioners, or who in fact a bit resilient about new technologies. So this is a good way of the second way of funding is at the European level as well.
Yeah. How do you cope with it in Northern Ireland, Janice?
We certainly don't have enough money at a regional level to fund the research we'd like to do. And we would tend to spend a lot of effort on identifying partnership funding with, it could be funders in the UK, it could be the EU funding programs. But more recently, actually, since our Life Sciences Hub has been set up, there has been a lot more focus on looking at that kind of private support where not just for specific projects, but just to support the infrastructure to develop. And there's a lot of that seems to be going on in elsewhere in the UK from the pharma companies and the likes of the ABPI, the Association of British Pharmaceutical Industry, who are willing to put in amounts of money to support the infrastructure to create the platform that's needed. And I suppose the other thing to say is that we've had successive cycles of something driven from the policy level called Matrix Panel, which is a sort of multi-stakeholder panel of experts who have convened to identify strengths and opportunities that Northern Ireland could focus on. And both of the last, well, at least 2 out of the last 3 cycles have identified stratified personalized medicine, whatever you like to call it, as an area that, you know, we could have enough strength and be able to focus on. So I guess we have to try and be very strategic about our investment, and we have to try and supplement our local funding with all sorts of other supports in whatever way we can. So that's how we get by.
Yeah. What I still don't understand is that why is it so difficult to collaborate? Why is there to find the right person? Cynthia said, why is it so difficult with the regions to work together or
No,
or
that's
to
not
find
right.
each other? No? Okay.
Sorry, correction
No, no,
here.
okay.
No, I think this is not right because there is
That's the impression I got.
collaboration.
Yeah.
This is, for instance, what IRA Permit is about. It's about collaborative transnational projects
Yeah.
in personalized medicine. Yeah, and there have been 5 calls, and of course, research groups collaborate. I think it's always the level of what we're looking here. If you look at research and innovation, for instance, of course, you can do project funding. You can have ideas of researchers that you can fund. Also, clinical research, yeah, investigator-initiated studies, I think, are really important sometimes to drive things forward. But then you have also to think about translation and commercialization, and there you need different funding and different amount of money and different actors. This is something that is moving things from, well, partially from the public domain to the private domain to make it usable. Yeah, because someone has to take over the cost for developing a product to the market, for financing all the clinical studies and so on. And here you need a different amount of funding. And also then if you think about research and different sources of funding, okay? And this may be an issue also in Europe. I'm not sure. I think I have the impression it's changing. For instance, venture capital, I think, has improved greatly over the last few years, also maybe in the context of the COVID pandemic and the successes of companies like BioNTech, for instance. But also, of course, you need a capital market. And if you look at the sums that are moved, I just heard at a conference, I heard a talk, I think Irene Norstedt was talking about funding projects in rare diseases, EJP rare diseases, where we have like 100 million available. I read an article of an American professor who set up a company on rare disease research and development with one of his former students, and they just managed to raise 1 billion of private money to fund rare disease projects. And he had a very nice rationale for this, arguing that rare diseases are especially good for being funded because they are not related. You have different research concepts behind, and so you have a risk reduction. I thought this was interesting. I thought this is, of course, very, well, you have a different size, and it's about scale to some degree. So also, but, you know, in funding, you can do nice projects on a regional level, but certain topics, you need a large amount of funding, and this is not in the scope of regions.
No.
You need interregional collaboration, but you need also sometimes to have size. in scale.
Yeah.
And for that,
And that, of course,
yeah.
is different for,
Yeah, that is very, very important. We shouldn't forget that.
Okay, that was very clear. Thank you. Jonathan, would like to add something?
Yeah, I agree completely. I think the best model when you want to bring something to the society in the end is a public-private collaboration. So you have to transfer all the research and innovation to to the market in the end. And the thing is, you have to collaborate with the industry every time in equal. For example, we are not getting money for that. I mean, we can explore different models to for royalties and so on. But as a public system, as we are not really interested in this. We are more interested in having a good service that then the company, when we co-design with them, we have a preference, or we pay less, or we have some benefits because we were part of the design of this. But it's essential to collaborate with the industry, and we are doing many different projects funded by the industry, and we put the rules from the beginning. So it's not like a clinical trial when they put money to do the clinical trial, and then this drug comes again to the system, double, triple, price, and they pay a little, but then you pay more when you put it into the system. We are not doing that, but it's essential to explore the collaboration with the industry, especially to avoid all these many different pilots. So we are doing pilots and pilots. We mentioned that. So pilots are good, but everybody knows that many pilots in the end, most of them are not worth it. And you spend time, you spend money, and when you have the industry that has the focus on, I really want this pilot, and this pilot will be ending in something, really successful. So I think
that's the better thing to do. Yeah. Okay. We're nearly at the end. Is there anybody in the audience who has a question? Somebody? Yeah? The gentleman there in the middle.
Thank you very much. Some considerations and then a question. First of all, thanks for the debate, very interesting. My name is Vincent Moa, I'm a Belgian. I'm working in Italy in a science and technology park in a province next to Olivia, province of Bolzano, and we don't know each other. So that's a good example that we still have to improve.
Yeah.
What I noticed is that, so at the end, it's about that data. So first of all, we have to find the data. First of all, have the trust that the people are okay with sharing their data. Then we have to store it, and then we have to process it. I have the impression that everybody with very good intention, maybe I'm wrong, is doing the best that he can, but on his own single, isolated manner. Don't we need a more kind of European governments and maybe European guidelines, standardizations? For example, that European data science cloud that I saw before in the presentation. I didn't hear any one of you. Maybe you're using it, okay.
No.
So maybe that is something that should be further developed, a kind of a common standard where we put the data, because at the end it's, the bigger the pool of data we have, the better analysis and artificial intelligence we can apply onto it, and the better the result will be. So coming to my conclusion, shouldn't we not need on European level a guidance and a standardization to put those data together, put all those projects together, and move forward more quicker in a more coordinated manner?
Yeah, I think that's why they made the roadmap. No,
I think the presentation we had today,
It is also ongoing in the context of Europe with the EU for health data. So that is really part of the thing. So every new initiative that is started on data collection should be aligned with the agreed approach in all over Europe.
Okay, perhaps Eva Maria, you would like to comment?
Yeah, we just had this presentation today from, I cannot pronounce the name correct, Simon Bilecki.
Yeah, Bilecki,
Who's showed many initiatives on data, and I think that's very good and highly relevant for personalized medicine. I think it's really, really important to have the European health data space and to move one step forward and have a good regulation. And I think, but data is also a topic that probably regions should think about, because data, apart from interoperability, also data storage and maintenance and data transport is not that simple. Just one little story. I talked to someone who said that the Charité University Hospital, they bought one of these wonderful sequencers from Illumina. It took them half a year to get it working because they did not have the capacity to transport the data. Also, it's just a technical angle of this, but it's also very important, I think, for the regions. Yeah.
Another question? Yeah.
Well, it's maybe more a comment, but maybe also a question. It was about the discussion on how we can help our healthcare professionals. And I think one aspect I missed, and that was, I think we need to look at the problem from two angles, because it's very different if you take from specialist area, from secondary, tertiary care, and then compare to the GP in primary care. Because if you take in the specialist areas, cancer, for example, I mean, this is where we see the good examples. This is where we see, for example, the French cancer plan and so on. It's possible because it's a more well-defined, more narrow area. It's possible to set up systems that works for the doctor and can help the healthcare professional. If you go to the GP, I mean, he's meeting all kinds of patients. And a lot of the big diseases, like, for example, metabolic diseases, cardiovascular diseases, and others, are driven, the treatment of these patients are driven mainly from the GP practice. And how do we help the GPs? And this is kind of where I see our current health system fails. This is where we need a revision of our healthcare system, because we cannot provide a GP with setups like we do in cancer, because then he would need to deal with setups in 5, 6, 7 different diseases, and he cannot cope with that. So we need to find other solutions to help the GP in his practice. And so it's more common. I don't know whether you have any thoughts on that, but I see it's two very different types of problems we are dealing with.
But it's very complex, that's true. Another question over there? Yeah? Yeah, go ahead, yeah.
Okay, thank you. So putting my SAPHIRE Health Economic Working Group hats on, I was wondering at the regional level, what was the required level of evidence required, including pharmacoeconomics and like all the costing issue, acknowledging that there's a fixed envelope and taking funds away from the health envelope to put it in those new approaches might deprive other areas. So in your, and also linking that, maybe what would be the place potentially of linking that with research and the value of having access to data evidence generated in a clinical context, and to feed that into research to actually build that evidence and promote further implementation and support stronger deployment of personalized medicine approaches.
Mm-hmm. Your question is for?
I think it kind of
What,
bridged the clinical aspects actually,
Yeah.
and how, if that was ever considered, or if that was just a political decision to say that we will do personalized medicine in our region. So how this is decided, and how the second part, how research could actually be, by promoting the use of data in research, of clinical data in research, how that could support further that implementation in other regions. And maybe having a champion in somewhere might provide a lab or a place where we can generate that, which would be really exciting.
Yeah, Jonathan, would you like to comment?
Yeah, I will tell you our experience. Our personalized or precision medicine strategy came from the basic research. One clinician doing research was interested in doing different projects, more applied projects to improve the healthcare system. And we write a proposal, and we were talking to the Ministry of Science and Economy and so on. And the idea was fine, and we were in this line. When you are engaging also a political level, so you now have all the support to do it, not only for using funding, that also happened, but also all, the political support, to have the space in the hospital, to set up all the different equipment and so on, to implement well the funding that is coming and so on. So, and then when you have funding, political support, you have everything to implement it. For sure, will be a pilot, because this pre-commercial procurement project will be a pilot only with 3,000 patients in our healthcare system. But for sure, will we scale it up? It will be implemented, because it's probably not all the functionalities. Probably we are very ambitious from the beginning, but it's a pilot to see, is it working or not? But this is the idea, and actually I think somehow we are mentioned we need the political support, we need funding, and we need practitioners and users engaged. So if you have everything, which it's this is so difficult. No, it's possible. But if you have these four, so for sure you will be a success.
Yeah. The gentleman over there. Question?
Okay. No question, maybe more comment. Thank you for very interesting discussion for full day. But I try and analyze this title, personalized medicine in European regions, because we probably use several definitions like evidence-based medicine, precise medicine, personalized medicine. What is the difference? And what is the role of region, authority, and community with this? Of course, for evidence medicine and for precise medicine, we need data and all. But data, it is not a problem of region, because it's a big politics, it is big business, not any role for region. If we think about the personalized medicine, that we think about the person, how to help the person. We not need the information only about disease. We need the information about the person, the human, the customs, etc. For human life, we more need good friends, good neighbors than doctors. For instance, in Poland, we have 2 million people who care full day in home, the person who needs full day help because disabled, etc., etc. And no one help him. 2 million people haven't any life, because all his life is connected with the help of people in his home, because we haven't any solution for it. That I think that for instance, for very old people and for very young people, we don't need any innovation like electronic gadget, etc. We need heart and hand. We need human internship relation. And it is the clue of region, to educate the people, to create the situation that life in this region is better than in another region, because it is the role of this authority community, educate the people and create good place for life with disease or without disease, because all of life is connected with several problems, and the value of life. It is the more important fact looking for the person who lived in this region.
Mm-hmm. Yeah, it all starts with the patient and put the patient in the middle.
It's something we always forget, and regarding the data. So the data belongs to the patient, and that's one of the reasons why all the regions, entities, countries are not collaborating as much as they can, essentially because they feel the data belongs to them. So I'm actually in my healthcare system. The healthcare system is only the custodian of the data, but they think the data belongs to them, and it's not that. When we understand that the data belongs to the patient, probably we will open up everything and we start to collaborate, because the rights goes to the patient. So the patient has the right to decide if he or she wants to give the data, the entire data, electronic health record, to another entity, to the private sector or whatever. And we in the public system, we are really concerned about, the private system is getting our data and they are gonna make business. You don't want to this. So the patient is the one choosing the final end of the data, not the healthcare system. Only the healthcare system is the custodian. If the patient decides to share the data to another country, for example, so why don't?
Yeah, of course, it all starts with the patient. Yeah, true. Yeah. Is there a lack of trust a little bit between the regions? No?
It's not about a lack of trust between the regions. It's about maybe sometimes knowing of each other. Sometimes there may be competitive situations, of course, also in research, it's also to some degree competitive, but I think there's a lot of potential for collaboration. And I think it's very important to have a good basis for collaboration, to have setups for collaboration, like the EP permit. Yeah. I think that's a very nice tool for regions to become engaged.
I think we can all be. It is clear that collaboration and working together is key. Is the main thing, and it's quite complex. I understood. So, if there are no more questions, I would like to end this afternoon here. And I think it's clear that the SAPHIRE roadmap can help regions that want to focus more on the development and implementation of personalized medicine. And we have to be, there is of course this patient centricity that we need to put the patient in the middle, and that he's really in control of his own health. But I think it's still a very interesting journey, and I would like to thank you, all the panelists, for your contribution. And I would like to thank you, dear audience, for attending and for your patience. Oh yeah, there's still a little gift. So thank you very much. I think it's Belgian chocolates. Okay. So for the online viewers, we welcome you back tomorrow at 10 o'clock. And for the people live in Brussels, you are welcome to join now the reception and the walking dinner. It's upstairs, and doors open tomorrow at 9 o'clock. So see you tomorrow. Stay healthy and stay safe. Thank you.